Hello, everyone. Thanks for joining us for today's panel. I want to thank our organizers at the Building Bridges Conference. Thanks to many friends and partners here in the room and joining us online. I was at a meeting earlier today at the Global Fund and meeting some new colleagues, and of course we were all wearing our masks, and at the end of the meeting someone said, "I look forward to meeting the bottom half of your faces." So I look forward to meeting the bottom half of many of your faces soon. I'm Martin Edlund. I'm the CEO of Malaria No More and also the Executive Director of the Health Finance Coalition. And I'll be moderating this session, which is titled Real Blending, Attracting Private Capital to Global Health. And this is organized by the Global Fund and our organization, the Health Finance Coalition. You know, the Building Bridges Conference is really a great concept and a perfect context for this conversation. Building Bridges, of course, is about bringing together the two sides of this city, Geneva, the global health community and the global finance community. And we're convinced that it's these two sides that are going to have to come together to really solve one of our most urgent global challenges, which is the health financing gap, especially in the context of the COVID pandemic. So we have a fantastic panel, whom I'll introduce in just a moment. We had hoped to have more of them on the stage with us, but thank you to Catherine for being here in person and the others for joining us virtually. You know, in this way, it will give us a sense for how global this community is. We have panelists who are joining from Tunis, from Botswana, from the Netherlands, and you'll be seeing them shortly. Just to set the stage for this discussion, let me start with a few numbers that really frame the scope and scale of the challenge that we're trying to solve. Our friends at the WHO would tell us that the world faces about a $240 billion financing gap. That's the additional money that's needed each year between now and 2030 if we want to achieve the world's global health goals, SDG 3, the goals around universal health coverage and primary health care. The need is greatest, of course, in places like sub-Saharan Africa, which accounts for 23% of the global disease burden and yet only 1% of global health spending. Even if you click into something like the $500 billion that's invested in social impact investing markets, only a meager 1.6% of that is spent each year on healthcare in Africa. So we've really got our work cut out for us today. And if you were to click into that 1.6%, what you'd find is that most of that money is actually spent on city centers, middle class and above audiences. And so, you know, our challenge is really how do we mobilize more money, but also how do we direct that money where the need is greatest, investing in the bottom of the pyramid, investing in the innovations that are going to create the most health impact. And of course, this challenge is made only more dire in the context of COVID-19 and, of course, with the recent news of Omicron, you know, the latest variant that was identified in South Africa and is already impacting many of the economies and health systems there as we see closures that kept some of our participants off the stage today. But we at the Health Finance Coalition think this is actually the moment to precipitate a change. We think this is the moment where we need a new approach to global health financing, one that positions private return-seeking capital to invest alongside and in coordination with the world's biggest donor institutions and with African governments to scale transformative health innovations. We call that taking a capital stack approach, really bringing those different sources of capital together to support novel, concrete initiatives, and our mission is to show a path to scale for this capital stack investing approach. So let me, without further ado, introduce our panel. What I'll do is introduce them briefly, just tell you their names and titles and locations, and then I'll go back through and pose some questions to each of them. And then I want to let everyone know that we'll be taking questions from the audience, both here in the room, in Geneva, and those who are online. So be thinking of questions. I understand that there's a way for people to submit questions online, and so we'll figure out, we may have our colleague Ashling running up on stage and asking those questions as we go. So to our panelists, in alphabetical order, let me introduce John Fairhurst, the head of private sector engagement at the Global Fund, our co-host for this session, and he's here in Geneva. Sarah Fisher, the global public health financing lead for Johnson & Johnson, and she's joining us from the Netherlands. Samia Gorbel, a senior partner at Africa Invest, which is one of the most experienced private equity, venture, and debt fund managers in Africa. Samia, thanks for joining us from Tunis. Catherine Howell, here in the room, the innovative finance advisor for the International Committee of the Red Cross, and also importantly for this conversation, a board member for a social enterprise called Meds. And so we'll be talking about both the global and the local perspective with Catherine. And then Geeta Tharmaratnam. Geeta is the CEO and founder of an investment advisory firm, Equalitas Capital Partners. But Geeta has been involved in many of the health funds that have developed over the past decade or more. So she'll be drawing on all of that experience in the conversation today. And as I said, this is exactly the group that we want to be having this conversation. So we're going to give them the really hard questions. Hard questions like, what are the barriers to making a capital stack or blended finance approach work? How do we drive investment to the bottom of the pyramid, the areas where the need is greatest? And most importantly, how do we work at the scale of the problem that we're talking about? Many of you who've been following or involved in impact investing, there are many innovative things that have been done, but we're talking about a need of hundreds of billions of dollars affecting billions of human lives and livelihoods. So we really need to be thinking about how we work at appropriate scale. So I'll now circle back and ask some questions of our panelists. John, we're going to put you on the spot first. Many of you here in Geneva know the Global Fund. It's not far from where we are here at the Impact Hub today. The Global Fund is the world's largest grant financer of healthcare, and so you might ask yourself, what does that have to do with private investment and private enterprise? And so we'll turn to you first, John, to talk about that, and also to say a word about the partnership that we're announcing today between the Health Finance Coalition and the Global Fund. John, over to you. Are people hearing John? I know we're not hearing him here in the room. No.
Martin, can you hear me now?
We can. Loud and clear. Thanks, John.
Fantastic. Thanks for the introduction, and a pleasure to be here on, as you say, what is a really fantastic international, highly qualified, experienced panel too. I think you framed it really fantastically. The concept of building bridges is absolutely critical. So I think talking about this in the context of the Geneva landscape of building a bridge between the banks is important. But the concept of building a bridge between the sectors is I don't think is even just a nice to do anymore. It's essential that we do it, and we do it faster, bigger, and more effectively as well. What's important to us as well, I think it's very prescient, is today is World AIDS Day, and World AIDS Day is a really important day on so many levels, but it's also very relevant that the last pandemic that threatened the world, that in effect created the Global Fund as an institution was HIV and AIDS, and there's a huge amount of learning that is going into how we deal with COVID. But I think one of the critical pieces of learning is we have to break through in this context of bringing all forms of capital, to bear against these diseases, HIV, TB, malaria, all of the health issues. We will not solve them unless we mobilise every piece of capital, and we mobilise it in the most efficient and effective way that we possibly can. So, this conversation is fundamental. In the context of the Global Fund, why is this so important to us? I suspect for many of the people in the room, it's perhaps obvious, but the private sector plays a fundamental role in the provision of healthcare everywhere. If you look at fever diagnosis in a country like Nigeria, 70% of fever diagnosis is done in the private sector, whether that's TB, whether that's malaria, or whether it's COVID. That's a fundamental entry point for people's care into the private sector. Many of the services are provided in the countries where we work, in low-middle-income countries, are underpinned by the private sector. Supply chains, warehousing, technology, communications infrastructure is a private sector infrastructure that needs to be engaged as effectively as possible to drive health. And I think COVID-19 has brought an even bigger emphasis to that. Obviously, we've seen that global markets don't work effectively at the point of crisis. We haven't created equity of access to vaccines. We've seen supply limitations in protective equipment for health workers as well. And so this ability to build domestic manufacturing capacity, domestic service capacity, domestic lab capacity is also linked to the ability to build a fantastic and thriving private sector. And that's what will create resilience for future pandemics as well. So really central, and more important than ever, I think, that we drive it. And of course, like all organizations, we're defined by the tools we have at our disposal. And so if you're an organization that provides grant, then everything looks like it needs a grant, which of course we know not to be true and not the most efficient way of working. And similarly, if you only provide equity and debt, then everything looks like it maybe needs equity or debt. Where we know, of course, is that there's a space of the combination of those things, which is hugely powerful to build. And by deliberately bringing this capital stack together, we can leverage the scale of the Global Fund's procurement activities, the scale of our support for technical assistance and building health systems and capacities and staff, with a private sector which is very much aligned around the quality of services we need. And that's a space that I think, in the partnership with the HFC, we can really drive. And I think the point you made, Martin, is we need to make sure that impact is a central piece of what's guiding us here, that we're not looking at impact investing. We're looking at impact through investment. And that means making sure that the capital stack enables us to scale both effective and sustainable business that is very much driving quality care and impact through it. So, it's really fantastic to announce our partnership with the HFC to build out this blended finance in a capital stack approach. I think it's the start of a pattern that we all need to accelerate. And I think the Building Bridges conference is absolutely in line with that. So thanks for having me, and look forward to the discussion.
Thanks so much, Sean. And you made several important points there, but one of those is about, this is about bridging not just to private capital, but to private enterprise in terms of health service delivery, and that it's about both impact, which we all care about, but also investment. And the way that we're going to achieve scale is by actually having enterprises that promise a return and are kind of investable and sustainable from a private capital standpoint. Samia, let me turn to you. Africa Invest has been one of the leading investment fund managers on the continent. They've been at it for 27 years, and I know you've been there for a significant portion of that time. You and your colleagues have raised more than $2 billion to invest in enterprises in Africa. Importantly, you've also made, as I understand it, the most exits, more than 100 exits in businesses that you've invested in, so you really understand what it takes to invest sustainably and profitably in the continent. Can you talk about what barriers you see to making a capital stack approach real? And in particular, how do we get private capital working for the segments of the market of the greatest need? Over to you, Samia.
Thank you, Martin. Thank you for the intro, and a pleasure to be here and to meet you all. So indeed, Africa Invest, we've been investing. I mean, we're so far active since 1994 with an important experience investing in Africa. So we've been investing so far in the health space through our generalist fund and through our private credit vehicle. But so far, the investment that we made in health were serving the middle to high-end segment. So our conclusion is that today a large segment of the market remains uncovered. Sustainable and scalable projects that require patient capital, but targeting the bottom of the pyramid. So this is the main challenge that we see and that is still there. The other challenge that we see is the lack of high-impact investable, or what we call investment-ready projects. So deals that serve the bottom of the pyramid, but in the same time that meet the returns requirement of private investors. And from our experience, I mean, why these investment-ready opportunities are so low, actually? First, because of the high return targets that are being set today by private investors. Second is the lack of this coordination between the various capital providers. And third, also because a large part of these models actually are today not sustainable and needs to be reviewed because they are heavily relying on grants, basically. So what's the solution? What are the solutions that we see for that to address these challenges that we see in the high health impact space more specifically? So, and these are actually the challenges that we are addressing through our partnership with the Health Finance Coalition. So we recognize the need for an investment vehicle, and we are working on a setup and on a structure that would be addressing these challenges that we've highlighted. And this is basically what we are trying to do again with Transform Health Fund. So first, a fund with more realistic return target to enable investment where it is needed the most. This is the first point. Second point is to make real this blended capital structure that will catalyze private investment, improve return of private investors and protect their downsides. Third, the coordination and blending between the private capital, institutional investors, donors, such as the Global Health Fund, and governments. So blending would happen at the fund level, but also at the deal level through co-investments and partnership. Fourth point would be to set up a deal construction, what we call a deal construction facility, which is basically a technical assistance that would help review those models and make them sustainable. So make these unsustainable model investment ready to enable investment where it is needed the most while addressing the return requirement of private investors.
Thanks so much, Samia. And, it's so helpful to hear kind of practically what it takes to make investment work. And so, Samia pointed out it's at the kind of capital level, having realistic return expectations. And then at the pipeline level, having the support for enterprises to be investment ready. And then ultimately the hard work of coordinating that return-seeking investment and the non-dilutive grant capital at the deal level to make some of these deals work. So we look forward to hearing more about that work from you, Samia. Sarah, you are the Global Public Health Financing Lead for Johnson & Johnson. Of course, J&J is a pharmaceutical company, very much in the headlines and on the front lines of the COVID fight with the J&J vaccine. But you've been at the front lines of, as John put it, the previous pandemic that led to the creation of the Global Fund, HIV, and a number of other issues. How does J&J's mission and business benefit from a capital stack approach, and what are some examples of the challenges that you look to address in this way?
Sure, thanks, Martin. Yeah, so Johnson & Johnson, let me just highlight a few of our initiatives around the public health space, let's say. Our Global Community Impact Group has a Center for Healthcare Work Innovation as a leading effort. And a 2030 goal that they have is supporting 1 million healthcare workers to reach 100 million patients by 2030, as an example. Johnson & Johnson Impact Ventures, which is our debt and equity vehicle structure that was launched in 2019, focuses on pre-Series A and Series A investments in areas of health services, health workers, health equity in the geographies of East Africa, Southeast Asia, and the US. And then last but not least, where I sit in the Global Public Health Group, takes more of an end-to-end approach to discovery, development, and delivery. Also under its 2030 agenda, focusing on recently launched networks of satellite discovery centers, for example, for tackling pandemic threats, as well as cold chain and drone delivery efforts on the supply chain front. So there are a number of different uses of capital. So we have grant making, concessional capital, debt equity vehicles, and R&D and access efforts, all under our umbrella when it comes to public health agenda. I would say, the previous speaker spoke a lot about this, but there are frankly some things that are just not investment ready yet for private capital, which is why coalitions like this or building bridges events like these are so critical in order to tie catalytic capital and concessional capital to private investors, so that when those things become investment ready, you do have partners that are not only with you on the catalytic journey, but that are also there to help with refining the business models and making sure that there are return models for things that do stick. And there, I would say, there's a lot of focus now on blended finance structures. Although most of the research I see simply says that many people are not repeating them after doing one. So I think there's a lot for us to learn and work on there in terms of the elegance of these structures is really actually in their simplicity. So not overcomplicating what blended finance is, not overcomplicating by blending the finance all the way down even into the deal level, but maybe keeping the blended structures at a higher level. And then making deal execution and catalytic funding two separate actual actions, but that tie into each other so that there is sort of a runway effect. The other last thing I would say is just, events like these and conversations with partners that are included in the panel here do make it makes it a little bit easier for large private entities like ourselves also to not different types of catalytic or debt/equity vehicles to participate in. But the more siloed and one-off those conversations are, the more difficult it will be to actually pull together these pools of capital that we need to make a dent. So if we can agree on thematic areas like supply chain, like digital and data for low middle income countries, infrastructure building, healthcare workers, whatever the themes may be, but if we can create thematic pillars for folks to rally around, and then from there with the stakeholders at the table decide what sources and types of capital are most appropriate for deployment for which efforts, I think we make a lot more progress.
Fantastic. Thanks, Sarah. And one of the points that you made that I want to highlight is getting to a common definition of what's investable. One of the bridges we have to build is between the investment sector and the NGO sector and governments, because if you go and ask NGOs or governments, what does something investable look like, it may not bear any resemblance to kind of what the requirements are for private capital. So educating each other, working together, building that common pipeline is one of the key challenges. And then being realistic that there are certain things that are not investable. There's a really vital role for public sector spending and for grant spending on an ongoing basis in this work. Catherine, you've been very patient sitting here with me as we talk to the other panelists. You have such a unique perspective from your work with Red Cross, and as I understand it, you were deeply involved in the first humanitarian impact bond back in 2017. So you've been thinking about and developing and leading on these global structures. But you're also on the board of Maisha Meds. And Maisha Meds is a social enterprise, one that builds digital tools to help clinics and pharmacies and frontline drug shops in low and middle income countries to manage sale and inventory, to source quality medication, and even to do some really innovative work. We're talking and partnering with them on solving challenges like malaria and how you create subsidies for things like rapid diagnostic tests and so forth. So maybe we can start there, and you can give us a perspective from kind of the social enterprise or operator standpoint. How do you think about building that business and building a capital stack of your own between private investment and public donor monies?
Great. Thank you, and thank you for the invite today. You did say we'd get the difficult questions, so it's not an easy one, first up. But first to my experience with Maisha Meds, as Martin said, I'm a board member on Maisha Meds. And the company have really been on a sort of short but very high growth journey, spun out of Stanford and operationalized in Kenya about 5 or 6 years ago. And now they're operating in over 5 countries. And to John's point earlier, a lot of people, a lot of patients seeking to access healthcare in places like Kenya, in the Congo, in Tanzania and Uganda, they're going to these small clinics and private pharmacies. There's lots of reasons for that. And really what Maisha are looking to do, as you mentioned, is use technology to improve the care that those pharmacists and small clinics can provide. And the way they do that is enabling technology through point of sale system. They're working up the value chain as well and connecting to distributors, so through a reordering system. And they're also working through the value chain, so into the sort of patient care level. Through their system, they can provide very targeted responses to certain cases, for example, like malaria, where oftentimes, if you think about malaria treatment, people are coming to a small clinic and may not have the money to buy a test, and so they just buy the drugs. And 50% of the time, people actually don't need the drugs because they haven't actually tested. And so all of these very persistent and complex problems that are happening with millions of people accessing care in sub-Saharan Africa is something that Maisha is really looking to drive technology to solve. It's a very mission-focused organization. To date, they have taken on grant capital. Familiar names like Gates and USAID have funded Maisha Meds to date. And really, Maisha's on a mission to sort of grow their network. So this is where we get to the problem of, well, what type of capital? And you know, we look forward the next 5 years from where we are today in taking on grant capital with a network of around 1,000 providers. Maisha wants to scale to over 100,000 in the next 5 years. To put that into context, that's probably around 25 million patient encounters. That's an awful lot of data, that's an awful lot of technology, that's an awful lot of investment that's going to be needed to scale this business. Right now, Maisha, in terms of like their next stepping stone, are actually looking more in the sort of outcomes funding space. I think their technology lends brilliantly to looking at channeling outcomes funding, perhaps you know, even upfront investment, a little bit like a concept of an impact bond, but a fund could possibly take on then upfront impact investment. Maisha have also worked with the Medical Credit Fund. For those not familiar with the Medical Credit Fund, they basically provide credit to pharmacies and small clinics. So Maisha are connecting with funds that are providing credit into that value chain, and that's also a really critical component here. The challenge then is that sort of the next stage. You know, how do we get a sort of organization like Maisha Meds to investable, you know, stage? And I think that there are a couple of business lines within Maisha Meds, for example, the reordering system that's breaking even, it's profitable at the very small scale they're at today. if you think about the scale of Maisha Meds, the data that they have available is quite a significant leap, I think, for understanding global health and public health in certain countries. And there's definitely a market for that, and Maisha are proving that. So there's a few areas of the business that we know can be profitable in the future, and I think there is a path to profitability for Maisha Meds. And I'm really encouraged today by the launch of the fund because it not only acknowledges the need for a different type of capital to come to the sector, but also the expertise that comes with that. If you think Maisha being spun out from Stanford, is the CEO is a medical doctor, and she's fabulous. But she also, as a team, is now building a team of people around her who will also need expertise to do sort of business planning and thinking about what investability means. And if you're an organization that wants to go from grants to taking on investor capital, that requires a different kind of expertise. And I'm really thrilled that the fund has sort of acknowledged that it's not just about the money, it's about blending those expertise and bringing the different partners together. So I think I've probably closed there from the perspective of Maisha Meds. And just a final note, perhaps a nod to my other role at the International Committee of the Red Cross. Our work is really in this space of innovative finance in humanitarian settings. So we work in some of the hardest to reach places across the world. We launched the Impact Bond in 2017, and we're going to be following through with a number of transactions next year. And I think some of the challenges for us in this space is that, and I think somebody mentioned this earlier, right? The deal construction time, it's long, right? We see from investment advisory firms like Cross Boundary, a deal to construct in Mali is going to take 18 plus months, whereas an average deal on the continent may be 7 or 8 months, right? So patient capital, it's been said, and I think that the willingness of partners and individuals to come to this space, be patient with the capital, but also their sort of investment thesis, I think, is absolutely crucial. So I'll leave it there, but thank you very much.
Yeah, thanks, Catherine. So helpful to hear both those perspectives. And you talk about a business like Maisha Meds, it's the CEO is so dynamic. The team, they're not investment ready by many kind of investor criteria. And so having that construction capacity, being able to invest in those committed and passionate teams who have technology that can make a real difference is one of the keys, we think, to bringing these worlds together. Geeta, thank you for your patience. Want to turn to you last, but certainly not least on our panel. You've been at this for quite some time, 19 plus years of experience in private equity, venture capital, development finance, impact investing, insurance, and across different geographies, Africa, Asia, Latin America, and Europe. You've also, did we lose our panelists? We're having technical difficulties here in the room. Hopefully it's just here in the room. Let us see if Geeta and the panelists are still with us. All right. Well, we are going to work to get them back on the live stream, but are we still streaming from here in the room? Okay. So now is when we juggle and fill time from the stage. One of the things that I wanted to pick up on that you were saying, though, Catherine, is the role that a group like Maisha can play. And, I think it's one of the challenges that we have in this moment is we can no longer treat the public sector and the private sector as distinct in terms of health delivery. I've always been struck, I've worked on malaria for 15 years, at how much of the burden you're missing if you're not talking about the private sector, about 50%, we heard John say as much as 70% in a place like Nigeria of the fever treatment seeking goes through the private sector. And in a pre-COVID environment, maybe you can just accept that those two things are distinct, and you can make efforts to try to get quality treatment and diagnosis in the private sector. But in the context of a pandemic, we're really fighting it with one eye blind and one hand tied behind our back. So can you tell us a little bit about how MISHA can help to bridge those worlds between public and private service delivery?
Yes, absolutely. And I think you've touched on a really crucial point here, is that oftentimes when we're working just from one side, we're never going to complete the picture. And we see this in our work also at the ICRC. Our core mandate as a humanitarian actor is to protect and assist populations in conflict countries. But we can't be ignorant of the role of the private sector and the enormous role that it can play in helping to assist populations as well. With respect to MISHA, I think their technology isn't exclusive for private sector, but oftentimes, the small clinics and the pharmacies that are, maybe a 5-minute walk away are private clinics. And so their technology is definitely open also to the public side. And what they can also do...
I feel like every time we travel these days...
Oh.
Do we have our panelists back? Is that who we're hearing in the room? No.
But what MISHA can also do is connect their systems in terms of data and information to public health systems. So they're never sort of working on two different sides of a wall. They're trying to connect through that wall with the public health system in the country and with the digital systems that are in the country as well. So one of the really exciting elements of their technology is that whilst you could have, for example, global funders paying for outcomes today, particularly in countries where the public sector does have a low capacity, the future can be quite different. There could be the advent of health insurance coming from the private sector. There could be public health subsidies in that value chain as well. So there's definitely not a sort of exclusive, and it's very sort of symbiotic relationship. I think that we have to work in both domains simultaneously. And certainly acknowledge that whilst MISHA is sort of still very anchored in the private sector at the moment, it can build into the public sector, both from an information management perspective, from a public health perspective, sharing their data with public government bodies and ministries of health to really improve the public health system as well. So we see both as absolutely crucial.
Yeah, that's... I'm such a big believer in that, especially in this moment. A close partner to many of us is Dr. Raj Punjabi, who now leads the U.S. government's President's Malaria Initiative. And he has a great quote that I love to steal from him. He's a medical doctor, and he says, COVID's primary symptom is fever. Malaria's primary symptom is fever. Ebola's primary symptom was fever. And he'd bet his medical license that the next pandemic presents as fever as well. So getting that data from frontline caregivers in the private sector, sharing that with governments is so vital to how we respond. I see we have our panelists back. Welcome back, folks. Thanks for hanging on. Geeta, I was just about to turn to you. I was kind of midstream in running through your accolades and resume, but let me jump right into the question. You've been at this for some time. I'd love your perspective on what's different about this moment, this unique, hopefully once in a generation moment that we're in with the COVID pandemic, and how do we need to evolve our model to respond to this moment at the scale that's needed?
Thanks, Martin. I think the first thing to just acknowledge is health systems are built through collaboration. And by virtue of the fact that we're all sitting here around this table having this conversation right now is testament to that. And for that, what you need is also intermediaries, because intermediaries are able to move fast and to be able to try and build the next movement. And when I think of the next movement in terms of investing in healthcare in Africa, there's a wide spectrum which has not been funded the way that it should have been. So from a private investment perspective, right, if you look between 2013 and 2018, from the data that we have, only 3% of the capital that went in through private equity investments went into healthcare. Only 3%. It hasn't significantly improved since then. And so when you look at what is investable, just to pick up on some of the points that were discussed before, yes, it is difficult to find investable transactions, but they are not absent. So almost 8 years ago, we invested in a medical manufacturing business in Kenya. They were making syringes, disposable syringes. They took 3 years to get WHO Foundation certification. And once they did, they were the only ones in the country who were able to provide those syringes. Syringes, by the way, which were the only syringes allowed in government hospitals in Kenya. And in doing so, they dropped the prices of syringes by 1/3. So when I think about what we have to gain and the imperative of the moment we're in right now, it is about being able to recognize that investing in healthcare is going to go well beyond the sudden shock to the system that a lot more people have suddenly experienced or are aware of as a result of COVID. And I think a danger is going to be if we try to only focus on emergency healthcare right now, because this is our moment to put in the capital. This is our moment to put in the effort to build something which is going to be more sustainable over a longer period in time. So for me, what is going to drive this moment right now? It's a few things. You talked about the capital stack. The capital stack are the various instruments, right? So we're talking about equity. We're talking about debt. I would throw in there guarantee facilities, and I'd throw in there as well grants. But I think there's a matrix element to this as well, because you need to be able to cross-reference the capital stack against return expectations. What is not going to be helpful for investing in healthcare in Africa today is for us to get a whole load of private investors who are expecting 25% returns. That does not work. We know that we have a temporal issue when it comes to investing in healthcare. Healthcare businesses need a long time to grow. So the investability of transactions is only the first step. Arguably, the harder work is what you do after you invest to help these businesses institutionalize, to help these businesses grow. And that is as true on the service delivery side as it is on the development of medical products which are necessary. So if you look along the entire value chain of healthcare in Africa, there's a lot to it. And there are a lot of challenges, but at the same time, we need time. So any investors coming into the space need to be willing to stay invested in these facilities for a far longer period of time than other funds would have allowed for them to do. That's the first thing. The second thing is I think there needs to be a real conversation about what do financial returns look like. In a world where the currencies are fluctuating as much as they are across the continent, it is very difficult for a hard currency-based financing solution to come in and expect to get a return in hard currency within a short period of time. And when we talk patient capital, we're really talking about moving from 2-year funding to 5-year funding. That's not as patient as it really needs to be when it comes to investing in healthcare. So we need to make sure that investors who are coming in are not just understanding the temporal issue, but are understanding that with that is going to come arguably a lower return. Now, if you give a 10% return in the US, that is a solid return. But when you look at the risk profile of investing in Africa, most investors are not looking to invest and get less than 10 to 15% back. If you presume there's going to be attrition along the way in your investment portfolio, what this means is you start looking for the absolute best investments you think are going to give you the highest returns. And so when I think about the moment we're in right now, there are two types of deals we all need to be looking at doing. Those which are catalytic and which can scale over time, some of which are likely going to be higher risk, significantly higher risk, and then those which are more stable. However, we need to push those businesses which are more stable to be going outside of core urban centers, for example, to be expanding the range of services that they offer, etc. So the final thing that I'm going to say is in 2006, and this is what brought me into the space. In 2006, the IFC, the Bill and Melinda Gates Foundation, as well as McKinsey, did a 2-year review of the state of healthcare in Africa. And the output is a document which I still think is absolutely worth reading. It's about 135 pages, and it shocked all of us. I myself was born in Malawi, grew up in Zambia and Botswana. And as an African, I was still quite shocked by the findings in the report. Assuming that most high-income earners on the continent fly out for their healthcare services, the market on the continent, outside of a COVID situation where folks are maybe not able to travel as much as they are, is really about providing services to low and middle-income consumers. And looking at that group, this has been over 12 years ago, the findings of McKinsey was over 50% of this group, the bulk of whom are from the base of the pyramid, are paying out of pocket. 65% of their healthcare costs are paid out of pocket. And more than 50% of recognizing the very many thousands of healthcare businesses which are existing on the continent, many of whom have got entrepreneurs who are either elderly and looking to move on or institutionalize their businesses, many of whom there's been a lot of early stage businesses that have grown. I invested in 54 Gene last year, which is an innovative precision medicine business in Nigeria, which is doing gene mapping. Then there is the need to look at the value chain as well. There's been a logistics business, which is a quiet logistics business. It is the largest in the sub-region, and they're the ones who took the first Ebola vaccines into the DRC. And this was for a contract that was not awarded to them, but was awarded to one of the largest logistics businesses in the world, which then onward passed on the contract. So for me, what I would love to see for this moment is also a peeling back of the layers to show businesses which are already existing, because there's a lot there that can be done to bring them up to where they need to be able to take the large amounts of capital. Because I think if we focus only on startups, we're not going to get to where we need to get to. I think the final thing that I just wanted to mention here is when we look at investments, we normally talk about risk and return. But I would argue that no matter what, we have 3 elements of investments today, not just when it comes to healthcare, not just when it comes to healthcare in Africa, but especially for healthcare in Africa. We need to be looking at risk, return, and impact. And that allows for a true blending of objectives, which can then flow down into the businesses which are getting the capital, knowing that at the end of the day, they're as liable for performance on the return side as they are to meet KPIs around the impact side as well.
Thanks, Geeta. So many compelling points to pick up on there. One of them we're all familiar with the phrase, don't waste a good crisis. And I think as the world responds to this crisis, there are some real opportunities not to be wasted. And I think it is the moment to show a way forward for a capital stack approach. But you also don't want to misuse or misjudge a crisis. There are so many things being considered now. Domestic manufacturing was mentioned as one. And we need to make sure we're investing in a way that those are going to be successful and sustainable businesses. None of this is helped in the sector by white elephant investments that a few years from now aren't sustainable. So I heard several themes for how we respond appropriately to the moment. Patient capital, realistic returns, taking an equity-like approach to investments. So after you make an investment, continuing to work with the operators and teams. And then I heard a healthy tension between a focus on startups and scale, investing in and achieving scale. Sammy, I know you and I are talking frequently these days as we develop the concept for the Transform Health Fund. Do you want to pick up on any of those points and talk about how you're achieving some of those, the patients, the realistic returns in that context?
Indeed. Thank you, Martin, and thank you, Geeta, for this brilliant intervention. I mean, I think patient capital is really the important matter on which we should focus. And basically, we're working with the Health Finance Coalition on setting up our health fund, which we called Transform Health Fund. And basically here we are looking at setting up a structure of the fund that would allow for patient capital. So we understand that normal private equity structure would not work for the type of deals that we want to do. So here it's important to look at having longer fund life, longer investment period, allowing also for the redeployment of the funds in order to increase, reach better returns for private capital, for private investors, and of course, alongside this blended capital structure that we are setting up. And as participants were also saying, I mean, what is important also, because the type of companies we would be investing in are really the small-sized SMEs that require a lot of hand-holding. And within Africa Invest, I mean, we have been investing in the private sector since 27 years today, and we have this experience of following up companies. I mean, our work doesn't end. Our work really starts when we invest. I mean, even when we invest into debt instruments, we really act as an equity investors with a lot of hand-holding, a hands-on approach with the investing companies, bringing our experience, our network, and helping those companies to grow on this. So again, we are partnering with HFC together in a joint venture, and so both of us would bring our experience and our strength into this partnership. So HFC bringing their tremendous experience into the health space and impact, and on our side bringing our experience in Africa, our network, and the synergy with the whole platform, basically. So again, patient capital together. That would be included into the feature and to the setup of the fund, and this blended capital structure that would enable to catalyze private investment, allow for longer investment period, longer fund life, and allow investment where it is needed the most, actually.
Thanks, Samia. And I did promise that we'd take questions, so I just have one more question, then we'll open it up to the group, and this is an all-play question. The critical part of the ecosystem that we don't have represented on this panel, of course, is governments. And we all recognize how important it is that investments, strategies, the work that's happening is all in line with and in concert with government priorities. And yet it can be really challenging for governments and private enterprise to speak the same language and figure out how to work together. So from the experience of the panel, what's needed to help bridge between host governments where these investments are happening and both the investors and private enterprise that want to commit capital to these goals? Who wants to go first?
Martin, I'm happy to go first.
Oh, I see you have your hand raised, Geeta. There you go.
I'm happy to go first here, Martin. I think here is where the position of intermediaries is one I'm going to point to again. And when I think about something like the WHO Foundation, which is truly unique when it comes to the space of healthcare and the ability to connect between governments, the private sector, between other stakeholders in the healthcare space to move the agenda forward, I think this is absolutely critical. There's a second aspect of this as well. Once a year, you have the World Health Assembly, which is normally held in Geneva. And I've been going to that for many years. And you will find that there are many governments, especially finance ministers, who are more than ready to have this conversation. They've been having this conversation for a while. The issue, I think, as with most things, is when the rubber hits the road. How are you able to execute on this? And how are you able to truly match the kind of projects they believe are needed and are fundable to the capital that is being brought by the private sector. And so normally in our worlds, we tend to think about investing in the public sector, we think about investing in the private sector, and then we think about the third sector, we think about NGOs, faith-based organizations. In Africa, there's a significant amount of healthcare that's actually provided by healthcare, by faith-based organizations. And so there are many different types of healthcare financing that are necessary. The discussion with the ministers is one which I think needs to be met with some practical solutions, but also with a clear understanding or articulation of what the funding you are bringing to the table can truly finance, so that there isn't a misunderstanding of, okay, when you talk about private sector, you're actually coming in to build or to finance health management information systems for our primary care clinics. It's really about saying, no, this is what we are able to do, and we'd like to sit down with you and truly understand how it is that we can help be additive to the health system in your country. What is needed from your side, from your perception? We have also got, as part of the Sustainable Development Goals, the implementation of universal health coverage. This is a complete game changer, because this is what's bringing capital through the doors in terms of revenue for private health facilities in these countries to pay for access, the provision of services to low-income individuals. If we really want to get to providing access to a larger group of people, I don't believe we can do that and have the impact we wish to have as a global community without involving the government, especially through the provision of universal health coverage.
Thanks, Geeta. And as many in the room and on the panel know, there's a real maturing of national health insurance schemes, and that's a way that public financing is finding its way to private healthcare provision increasingly. Other comments from the panel on how we bridge the gap between governments and private sector and private investment? Catherine.
Happy to make a comment, maybe just with my ICRC hat back on. I mean, and you know, I'm working at the moment on a deal in the water sector in DRC, and with that, I think it's just to echo Geeta's point here, is that the role of intermediaries. I mean, ICRC's presence is absolutely crucial. On the ground boots, kind of understanding the challenges where there is sometimes a lack of government capacity, but taking a systems approach. I mean, you know, when we think about this project, which is not in the global health space, but it has a public health impact because it's access to clean water, it's not just about the provision of clean water, it's about taking a systems approach. So working in partnership with the government, as well as the private sector. And I think humanitarian actors, development actors, are seeing more and more that the sort of building bridges are between their sectors of humanitarian, development, private, and government. So it's this sort of real collaboration between those sectors that needs to happen. And acknowledging that in places like DRC, which have suffered from protracted crisis, you know, it's even harder, right? So, again, the point on patient capital, we need to work on long-term approaches and acknowledge that there aren't going to be quick fixes. So, really staying in there for the long run and building those partnerships and handoffs in an appropriate way. So, thank you.
Yeah, thanks. John, I wonder if you want to add a final word here. The Global Fund obviously works with host governments. Most of your funding goes directly to or is programmed in concert with those governments. How do you think about the private sector side of that conversation with the governments that you work with?
Yeah, no, it's a great question. I mean, to be brief, I mean, I do think that this construct of intermediaries is really central, and it's the role that as organisations, to Catherine's point, you know, we can play to be that bridge. I think the truth is we need examples of doing it, because examples of doing it will get governments more aligned on that it can be done. And so I think, you know, the power of building, you know, a fund and the partnership is exactly that we build a case set of examples, and, you know, to Geeta's point, we can show them being bigger than just sort of cool ideas, but a track record of going to a bigger scale, making sustainable models with impact. Because I think the truth is we bridge, a number of ministries here. The Ministry of Health is the one that cares about impact. The Ministry of Finance is the one that cares about economic development. If we can bring examples that further both of their agendas for the country, then we will get both of their support in taking this agenda forward. So I think bridging that conversation, and as we know, and I speak, I guess, probably in a room of finance people, so the health people won't shout at me much. The challenge is that the Ministry of Health or the Ministry of Finance, Ministry of Economic Development or whatever, don't speak the same language at all. So I think bridging that conversation is going to be really central to the success of engaging government in supporting and building the right environment to make this successful.
Thanks, John. So let's open it up to the room and to those who are joining us virtually. Those here in Geneva braved very cold rain to get here and want to take some questions from this group. Or Aisling, over to you if there are questions coming from online participants. Yes.
Thank you very much, Christoph Stückeberger from Geneva. Working in Africa since a long time, my question to Gita, but also the others is, this conviction that we cannot make it with 10% return, otherwise we'll never go to Africa or to remote areas. How to convince investors to say, look, 2% in hard currency, that's reasonable, that's feasible, 1%, 2%, but not more. A big investor and entrepreneur of a big company in Switzerland told me already 20 years ago, he said, look, on a long term, we cannot expect more than the 2%. That's my lifelong experience in business. So how to convince other entrepreneurs, investors, to do that, to change this mindset in that perspective?
Great, thanks for that question. Gita, he called you out, so we'll throw to you first. Samia, I also want to get your perspective on this. Gita.
Sure. So in 2009, we raised $105 million to set up Africa's first health fund, which was aiming to increase access to affordable healthcare in Africa. At that point, the single biggest investor in that fund was the Development Bank of South Africa, who put in 1/5 of that fund. So I think when we talk about risk and the risk premium associated with investing in Africa, there are two things I'd want to touch on. The first of which is, how is risk actually evaluated? It is the cost of capital plus whatever you think is the likely cost of you investing in this region versus somewhere else in the world. Now, that tends to hover at about 22 to 25% when it comes to investing in Africa. And that is healthcare agnostic. It's across all sectors. That is the Africa risk premium, so to speak. And so I think being able to bring a diversity of investors to the table who have a deeper understanding of the continent is one way to address that. And that means getting our pension funds on the continent to be opening up their allocations. It means getting local investors on the continent to be opening up their allocations, because they understand that 25% is not sensible as a return, and they're very happy with something which is lower than that. So that's the first thing. Can we bring a variety of investors who have a deep understanding, comfort with the region, and can understand that the risk premium is priced too high, full stop? The second thing for me is where the power of blending comes in. And healthcare is such a natural place to be able to blend three types of capital. One is traditional FDI capital, which does not have, for the most part, a return objective. The second is impact investors, who are far more driven by the outcomes of the investments than a clear financial incentive. And then you have the private investors who are coming in. And you can create a tiered stack within the shareholding structure of the mechanism that you're using to invest in the continent, which means that somebody who is coming in without an intent to get a return is going to leave without that return. And part of their capital can go into blend and attract investors who are expecting a higher return. And it's not to, I don't believe of this approach as being something which is rewarding those who are overly pricing risk in Africa. But I think we need to get those first large investors coming in who are able to show that they've taken the risk. There have been good investments made which have brought the health outcomes that we are seeking. We cannot lose track of that, and that they have been able to get the funding back. And we have not just case studies, but we have data. For a very long time, when we talk about the impact investment space in Africa, when we're talking about healthcare investing, we fall back on stories. What we need is sufficient stories to turn into numbers, because that's what's going to drive, I think, the imperative there.
Thanks, Geeta. Samia, over to you.
Thank you, Geeta. I mean, I would add also, in parallel to what Geeta mentioned, I will provide an example of a new segment that we've been creating within African Invest. So in 2007, we launched in a different segment, basically, in a different sector. In 2007, we launched our first specialized fund, which was in the financial sector for Africa, basically. And this was a classic, typical private equity fund of 10 years fund life. And we brought different type of investors, mainly DFIs, who are our largest investor base. But basically what we understood over the time and what we discovered is that to really be impactful in the financial sector and to provide the right time for investment to scale, and also linked to some regulatory aspects, which are basically have to do with central banks, etc. We need the investment, the holding period needs to be longer than the typical 5 or 6 years holding period that we have in classical private equity fund of 10 years fund life. And so this is something that we discovered, but also that our investor came to this conclusion. And I think we need a lot of education in the space, and we've been quite instrumental in the ecosystem. And guess what? In 2018, we closed the second generation of financial sector fund, which was basically an evergreen vehicle, because investors came to the understanding that in order to be impactful, we, for this specific sector, so financial sector, we need longer holding period. And I believe that, I mean, our intention basically would be the same. So today we are working on the first high impact health fund within the group. Our intention, of course, is that this would be successful and we would go and launch another second generation and third generation of health fund. And our understanding would be, okay, we will start with a fund that would have a longer fund life than a classical, typical PE fund. But at the end of the day, our intention is to create a segment here, a new segment. And at the end of the day, we want to bring people together, an investor and all the community, to the same understanding than us, that we need patient capital. And in order to provide those a decent level of return, we would need to go for longer investment period and longer fund life, and even, why not, I mean, evergreen type of structure, basically.
Thanks to you both. And, you know, one of the things that stood out for me in the question is, you know, is it about convincing investors to have a very different return expectation, or is it about changing the ecosystem and through kind of changing the structure of the funds and deals to enable different investor types to come together? And I think what we heard is a lot of strategies for reducing the perception of risk, reducing the cost of risk, blending different investors to get people to their right return expectations, and then educating investors about what's needed for a particular segment in terms of timescale and patience. Other questions? Yes, there.
Hello, I'm Shariha from Mission & Co. Really interesting discussion and very much on point on some of the challenges that we need to overcome as a community. Sorry, I just wanted to pick up on what you mentioned about the focus on the ecosystem, because I think that really is the real immediate opportunity that we can work on, particularly with those who are already in the room, those who are already working on things, and those who are joining us virtually. We're all here because we are interested or we are already working on something. And the missing piece here is that recognition of the role of intermediaries, all types of intermediaries. You know, it's not just the financial intermediaries, there are also capacity building, you know, the academic community, they're also intermediaries, right? Strengthening the research and development. You know, there's so many other ambitions in Africa for building the economy, but it seems like we're trying to create this in a way that it's not linking with the other economic ambitions, right? We're saying this is something like we're trying to fill a gap, whereas I think the opportunity really is picking up on what Gita said. We've got to work with the existing large businesses that are driving the economies, that have already successfully raised financing, and find a way that we can connect those corporations with those entities that are just starting off or doing amazing things that nobody really was interested all this while to fund, to really close that gap. Just wanted to hear what your thoughts are around that, please, Samia, and of course anyone else from the coalition. Thank you.
Yeah, lots of points to pick up on there, and Samia, I'll turn to you in just a second. One quick response from the Health Finance Coalition side. I think increasingly people are recognizing that it's a false dichotomy between the economy and health. You know, if COVID has shown us anything, it's how vulnerable the entire economic system is to disruptions from health. Earlier in the panel, someone mentioned the Medical Credit Fund, which lends to SME health providers. So one of the first things we did as the Health Finance Coalition as COVID emerged was to raise a $35 million loan guarantee facility, essentially to backstop and enable lending to frontline clinics, many of which were failing and closing right when they were needed most in the context of the pandemic. And so I think part of the investment case is we need a robust private and public health response. It needs to be stable. It needs to be up to the task of the moment in order for the rest of the economy to thrive. With that, Samia and the rest of the panel, turn to you for any other responses. Samia, you're on mute, at least here in the room.
Thank you. I didn't realize that. Thank you, Martin. Indeed, I mean, here, just to cover on health, so we've been so far sector agnostic within African Invest with a certain number of specialized initiatives. But in terms of health, I mean, and I think we saw that with COVID, how critical is health services within Africa, and how vulnerable has been the continent with COVID. I mean, with the disruption of essential services, a disruption of supply chain. So for this fund more particularly, and as Gita mentioned, it's about working with new businesses, but it's also about funding existing businesses. Bring them to scale and make them grow, make them also, what is important also to us, is grow beyond their border. So for us, it's very important, and we believe it's critical also in terms of investment strategy, as this enables also to diversify the risk, to look at opportunity that we can bring, that existing opportunity in countries that we can bring outside outside of their country, in the neighbored country. And basically in Africa, and essentially in sub-Saharan Africa, this has been quite possible so far, because market, especially few region, I'm referring, for instance, to the East Africa region, which is quite integrated in terms of regulation. So it's important to invest into existing new startup business, but also existing small businesses, and bring them up to scale, bring them to other neighbored country, and this. In terms of investment strategy, this would help also diversifying the risk, but also exporting some successful models outside of their border, basically.
Thanks, Samia. Sarah, I wanted to direct one kind of part of that question to you as well, which is, how do we bring new players to the table, right? How do we get new investors and partners? J&J has been a leader among pharmaceuticals and health corporates in this space, but what is it going to take to bring your peer group to thinking and operating in the same way?
Sure, yeah. So, I think even within the J&J type environment, in the large private sector environment, there are new vehicles that are being used in terms of financing tools that we haven't done 10 years ago, 5 years ago, if you looked back, didn't exist within our house either. So I think it's worth recognizing that a lot of the things that we've spoken about today, we haven't touched on even a fraction of the types of financing tools that can be utilized, whether it's supply chain financing or redeemable grants or quasi-equity. So a lot of times I think when we get stuck in these conversations, we think black and white investment, we think, it has to be a certain percentage of return, but even in the three different aspects that I mentioned of J&J working on public health efforts, you have everything from grant making capabilities to debt into equity, into R&D financing. So to bring new people into the fold, I think we need to start speaking the language of financing beyond what we've talked about in the panel today. And I think, Casey, you mentioned things like guarantees, right? How do we take care of currency risk in countries? So when you make an investment in a certain location, and if you have a drop in currency of 10%, who's going to cover that for those later stage equity parties who might be looking even for that 2% return? There are a lot of different tools that I've seen pop up, in recent years that we didn't really discuss yet today, but the people utilizing those tools are the new sources of capital. They're the new sources of capability that larger parties, like all of us here on this panel, need to start to bring into the fold, need to educate ourselves more about, what role can we play there in supporting different ways of using the capital. No matter what, it still starts with the investment thesis or the grant thesis. It starts with what's the problem that we're trying to solve and who are the right parties who have capabilities, not just capital, but the capabilities to help us get after that answer. And from there, creating a new capital structure or a new financing vehicle that supports getting after that agenda, I think is the right approach to it, rather than crowding in the capital and then just trying to figure out where you're going to spray the capital, because you've already created the capital structure at that point with a metric you need to hit. So doing it in the verse order gives everybody a lot more flexibility to kind of hit on the agenda and the need that we're actually trying to solve for, and then applying the new capital tools and vehicles that we have at our disposal to try to figure out how to ensure that that can be successfully financially sustained over time in these regions. So I think there's a lot of parties there that are working that were new to me in the last 5 years. But definitely even in the last 12 months that I didn't know were there. And it's parties like us, the big parties like us, that need to start to crowd them in.
Great points. How are we for time? Do we have time for one more question? So we have 3 minutes. So lightning round of responses if there's a final question from the room. Great, then here's a question, yes.
Thank you. From a private sector perspective, in healthcare, obviously, how a company can approach a fund like you I mean, what are your criteria, the ticket size? And then we have talking about, even these days, about equity. But are there any other financing schemes that maybe allow company, not really startups, but just maybe mezzanine financing or like midterm financing to raise their capital in your health coalition or even JNG and other structures? Thank you.
Yeah, it's a great question, and it's kind of the inverse of the point Sarah just made. We can't think about these hard and fast categories of equity and debt and mezz and grant and so forth. It's really gradations between those. Samia, maybe I'll turn to you for the question on if an enterprise is looking for to be considered by the Transform Health Fund, what do they do, and then how, in the context of the fund, are you thinking about different forms of investment? The perception is that we're only talking about equity, but I know that it's not just that. So over to you.
Great question, thank you. Yeah, indeed. I mean, in terms of size of investment, this would depend, of course, on the future of each fund, but I would discuss more particularly on Transform Health Fund and the fund we are setting up, basically. In terms of instruments, this varies a lot. We are not straight equity or straight debt. We would be looking at the characteristics of the company, its maturity, its its business plan, of course, how the company would grow, and we would really try to find the best appropriate instruments that would match with the company size today and also how it's going to grow and its cash flow generation over time. So very much looking into quasi-equity type of instruments. So instruments that would actually invoice a small interest coupon in the early years, but would grow over time as the company grow to provide sufficient time for the project to grow over time. So I mean, we do not have like a straight type of instrument. This would depend and vary a lot depending on the company, its maturity, its stage of development, and how it's going to grow over time with the fund that we would be providing, but also as per the trajectory that we would be working together with the management and with the sponsors.
Thanks. And thanks again to Building Bridges for hosting this conversation, an important one, a timely one, a rich one, a complex one in compelling ways, we hope. Thanks very much to our panelists first of all, for all the work that you're doing. We've talked today about needing to see demonstrations of the way forward if we're going to get to scale. And I think the five of you and many of you in the room and tuning in are working hard to build those demonstration projects and show the path to scale. So thanks for participating today. Thanks for your work. I would encourage all of you to reach out to those of us on the panel if you want to follow up and have conversations about what you're doing. And as we've said, this needs to be a room twice or three times this size next year. So let's keep bringing people to the discussion. Thanks, everyone.
Thank you.
Thank you.